Thanks very much, Don. Awesome information. Don gave the dates of the next two webinars. They're going to be specific to the acute low back and the mild traumatic brain injury. That's next Tuesday at 7:30. And the following week, 7:30 again on the Tuesday, is going to be the upper and lower extremities. We'll go over the inclusion criteria as well as the red flags, so that everybody is very much up to date on what needs to happen so we can start reporting cases. The links may not be up just yet, but we'll make sure that they're up by tomorrow for everybody so that they can view. And if you have any questions that you come up with after we've gone offline, please feel free to email Sarah. She's the one that's been sending you all the emails. She's been doing a great job trying to recruit as many of our colleagues as possible as well. So if you know of anybody else who hasn't yet signed up for the collection that may be interested, please speak to them and have them email Sarah. And if you'd like to be so bold as to pass their info on to us, then we'll give them a call or email them to make sure that they feel comfortable. So we had a question about the target start date for collection of data, and that would really be at the end of the month. So we're very, very close to our numbers. I'll be honest with you, we need 9 more to make our numbers, and we would like to have a little padding in case there's a few people that might drop out. So we're going to try and get as many people involved as possible, but at the end of the webinars in 2 weeks, we expect that we can begin our data collection. Another question, what would be considered to be a yellow flag? Would a list of examples for red and yellow flags be provided? Yes, absolutely. That will be on the criteria for each of the programs of care that will be on a link on the OATA website, hopefully by tomorrow. But it's outlined very specifically, and we'll review some of those when we host our webinar next week for acute low back and mild traumatic brain, and again the week following for upper and lower, so we can go over those. Okay, another question. Are patients required to consent for their data to be provided? No, they're not. It's maintained private all the time. They won't be identified, and it's your information as a provider. The discharge forms are quite simple, and when they're online, you can have a look. But ultimately, it asks you to identify the types of modalities or treatment that you provided, such as you would tick off that you provided exercise, such as you would tick off that you provided ultrasound, those types of things. Not that you did it on every single treatment, but that it was part of your treatment protocol. And you would indicate, I believe one of the questions is how many treatments were provided before discharge. So it gives us a summary, and that summary then gets evaluated by an independent source as we take all of the 500 or more cases per program of care and evaluate all that information. So there's no need for patient consent.
Yeah, the important thing to bear in mind is because there are no patient identifiers on the discharge report that you submit, then there is no need to obtain consent from your patients. If you want to explain to your patients what you're doing, and if you want to get consent, that's your own business, that's your own clinical practice or whatever, but it is certainly not required either by the law or by the OATA.
Are there any other questions? If you're thinking or formulating, just write that down so we can hold off for a moment. One of the largest questions that Sarah and I received in trying to really solicit people to participate was they were very concerned about a couple things. One was ethics. Did we need to go through an ethics board to begin our data collection? And what we answered to everybody is the reason that we haven't had to is because we're not trying to generate a study. This isn't a study. We're not trying to prove a theorem. We're merely collecting data and analyzing it for performance of programs of care. that have been devised and can be comparable to other professions because we can obtain that data through WSIB collection over the years. So it gives us a direct comparison. So it's not a study, it doesn't require ethics, it doesn't require consent, there's no double blind, all of those kinds of things. Are the parameters of the treatment required in the discharge? Parameters, I'm going to guess at what you're asking, but ultimately the discharge will ask the types of treatment modalities that you've used and the methods of treatment. So some might indicate manual techniques, some might indicate modalities, different modalities. And another question would be the number of treatments that were provided in the entire program. The assumption is that they've been discharged because they've returned to either activities of daily living, back to work, back to athletics or activity, back to sport. So if I've answered your question, great. If I haven't quite hit the mark, then if you could rephrase for me, great. Thanks, Darius. That's perfect. Okay, so I think that I've answered Darius's question. The other question that we were asked often was whether or not somebody that was dual credentialed or had more than one professional title was able to be included in the study, and the answer is yes. Because we are a profession that tends to have dual credentials, many different skill sets from continuing education, we're a group that tends to do a lot of continuing education. I think that this just proves our efficacy even greater, and as long as the techniques are within the program of care and we do our best to stick to the preferred techniques that have been validated for the programs of care, such as manual techniques. If you have advanced manual techniques because you're a massage therapist, or because you've done soft tissue release, or because you're an osteopath, osteopathic practitioner, then if manual techniques are included in the program of care, then feel free to include your advanced techniques. I think it will only show our results as stronger and will provide a greater apples-to-apples comparison when we're both saying what a wonderful profession we are and why people should include us in their insurance plan. Are there any other questions that we've yet to answer? Where on the OAT website? So they will be posted by tomorrow, I expect, and they will be, is there a special tab, gentlemen?
Under programs of care.
Under programs of care, we should have a tab, and all of the appropriate forms and the programs of care for you to view should be available there. Okay. Is it a conflict if patients receive treatment from multidisciplines? So a patient getting treatment for plantar fascia with AT practices, but also has had massage treatment or custom orthotic treatment?
Yeah, it should be exclusive.
It should be exclusive treatment. Custom orthotics? That's an external implement. So plantar fascia isn't part of the lower extremity. However, something like a patellofemoral may be. So a custom orthotic might be a particular course of action. I think that I think we can use our good judgment. My interpretation is that a custom orthotic is an external implement, not unlike taping. And if we were to do something of that regimen, it wouldn't be included in the preferred method, but it wouldn't be excluded or likely wouldn't exclude them. I would suspect if they receive treatments from other practitioners in conjunction, that would skew our results. So it really should be a patient receiving athletic therapy treatments only. Good question, though. That was a good one. Any other questions? if you wake up at 1 in the morning and you have a burning question, just jot it down. Make sure that you send Sarah an email, and we'll collect a few questions hopefully over the course of the next few days. So if she doesn't get back to you right away, please don't be discouraged. Sarah is excellent in getting back to people. So if she hasn't gotten back to you, either resend the email or just be patient for a couple of days, because what we'll likely do is collect a few questions from some people that will view the webinar off of the website, and then post all of the questions and answers and a bit of a frequently asked questions. So anybody who might have a similar question can have that answered as well, and Sarah doesn't have to go through it over and over again. So if that's all, we've just sort of got a last little note going out. Thank you very much for your participation. We anticipate that the next two webinars will go as quickly and easily as this one. This has been our introduction of the programs of care, their background, and how the process will work. And of course, next week we'll go over the mild traumatic brain injuries and acute low back, and the following week the upper and lower extremities. So if you're unable to attend live, please go and watch the videos at your leisure. Listen to the webinars at your leisure on the OETA site, and send any emails to Sarah. Okay, thank you, everybody. Have a great evening. Thanks for participating.